All right, if you're gearing up for your ATI pediatric exam, you are in exactly the right place. We are going to zero in on two endocrine disorders you absolutely positively have to know to crush that test: diabetes mellitus and growth hormone deficiency. Let's get right into it.
So here's our game plan. We're going to kick things off with a deep dive into diabetes mellitus, covering diagnosis, the nursing care, and of course those critical complications. Then we'll switch gears to growth hormone deficiency, and we'll wrap it all up by talking about the most important piece of the puzzle, your role as the nurse.
Okay, first up, diabetes mellitus. Look, to really nail these questions on your exam, you have to speak the language of diagnosis. And that language, well, it all comes down to some very specific numbers. So what is pediatric diabetes, really? At its heart, it's a metabolic mess-up. The body just can't handle its own blood sugar, either because it's not making enough insulin or the insulin it is making isn't working right. And the result? That classic, prolonged high blood sugar that sets everything else in motion. So what's the first magic number you have to burn into your brain? 126. A fasting blood glucose that's higher than 126 is a huge red flag for diagnosis. And remember, that word fasting is key. You have to make sure families understand that means absolutely nothing to eat or drink besides water for at least 8 hours. The other number you gotta know is 200. Now this one can pop up in a couple of ways. You might see a random blood sugar over 200 in a kid who's also showing all the classic signs, super thirsty, peeing all the time, or you might see it on an oral glucose tolerance test. Either way, a result over 200 is gonna confirm that diagnosis. So it's not just the number, it's the context. Now, this is where things get really interesting, because with kids, one size does not fit all. The HbA1c, or 3-month snapshot of glucose control, has different targets depending on age. For the little ones, under 6, we're actually aiming a bit higher, between 7.5 and 8.5%. So why would we do that? Well, because a severe low blood sugar event is so dangerous for a developing brain. As they get older and they can actually tell you, hey, I feel shaky, we can start to tighten that control. You for sure need to know these age-specific targets. Okay, so we've got the numbers, we've got the diagnosis, but what do we actually do? This is where we come in. It's all about our nursing priorities. And let me tell you, education is everything. This right here, this is the P. It's the foundation of all nutritional teaching for these families. 15 grams of carbs is one exchange. It's that simple. When you teach a family this concept, you're handing them the power to look at any food label and know exactly how to plan for it. You're giving them back a sense of control. And this is how that one core idea plays out in real life. It's all about consistency. You can't skip meals. It's about timing, matching the food to when the insulin is working its hardest. And it's about being prepared, especially with active kids. That snack 30 minutes before soccer practice, that's not a friendly suggestion. That's a critical safety rule to prevent a dangerous exercise-induced low. Oh, sick days. These are a huge source of anxiety for families and a really common topic on exams. See, when the body is sick, it's stressed and it pumps out hormones that can make blood sugar go haywire. The number one rule is you keep taking your insulin, no matter what, and you monitor like crazy, checking blood sugar and ketones every 3 hours. You push those sugar-free fluids, and you have to be crystal clear about when to call the doctor. Okay, let's shift gears to the scary stuff, the acute complications. This is where your quick thinking and sharp assessment skills can literally save a life. You have got to know the difference between these two emergencies in a split second. So let's make it simple. For hypoglycemia, think cold and clammy, needs some candy. The skin gets all cool, pale, and sweaty. For hyperglycemia, it's hot and dry, sugar's high. They're flushed, dehydrated, and listen, or rather smell. That fruity breath and DKA, that's the smell of ketones. It's a dead giveaway you are in a totally different kind of crisis. So if you even think it might be hypoglycemia, what's your first move? Always check the blood sugar. You have to know the number before you act. If they're awake and the sugar is low, you give them 10 to 15 grams of a simple carb. Think orange juice. Then you follow it up with something more substantial, like crackers, to keep them stable. But, and this is huge, if that child is unconscious, you never, ever put liquid in their mouth. That's a massive aspiration risk. That is when you reach for the injectable glucagon. Now, on the complete opposite end of the spectrum, we have DKA. And I want to be clear, this is not just high blood sugar. This is a full-blown metabolic meltdown. The body is so desperate for fuel that it starts burning fat like crazy.
That process creates waste products called ketones, and those ketones make the blood dangerously acidic. This is an absolute life-threatening emergency. Managing DKA is like conducting an orchestra, and it all happens in the ICU. Priority number 1 is always fluids to deal with that severe dehydration. Then you start a continuous IV drip of regular insulin to slowly bring that blood sugar down. Now here's the part that trips a lot of people up. As the blood glucose gets down to around 250, we actually add glucose to the IV fluids. I know it sounds nuts, right? But we do it to stop the sugar from crashing too fast, which could cause the brain to swell. And the whole time, you are watching their potassium levels like a hawk, because insulin shoves potassium into the cells and their levels can plummet, which is incredibly dangerous for the heart. All right, we have gone deep on diabetes, which is all about metabolism. Now let's switch gears and talk about another critical pediatric endocrine disorder. This one, all about growth. Let's talk growth hormone deficiency. So the classic picture here is a child who is noticeably short, but if you look closely, they're perfectly proportional. Their height and weight are in sync with each other. They're just small. This isn't about poor nutrition. It's a very specific hormone problem that starts in the pituitary gland. So how do we confirm it? With something called a GH stimulation test. It's a pretty intense procedure where we actually give a medication to try and force the pituitary gland to release growth hormone. Your job as the nurse here is huge. You're the one who preps the family, makes sure the child has been NPO, and then you're meticulously collecting all of those timed blood samples. It's a long day for everyone.
Okay, once we have that diagnosis locked in, the good news is that the management is pretty straightforward. It just requires a really big, long-term commitment from the family. Treatment is a medication called somatropin. It's basically a synthetic version of human growth hormone, and it's given as a little subcutaneous shot almost every single night. A huge part of our job is teaching the family how to do this correctly and just supporting them because they're going to be doing this for years. But it's not forever. We stop the treatment once their growth plates start to close, which we figure out by seeing their growth slow way down, and by checking their bone age on an X-ray. So let's pull all of this together. We've talked about 2 really different endocrine problems, right? One about metabolism, one about growth. But there's one powerful thing they both have in common. And that common thread, it's you. You are the center of it all. The pediatric nurse is the one doing the careful assessments, making the life-saving moves, and, maybe most importantly, giving the entire family the knowledge and the confidence they need to handle this new life every single day. And that really brings us to the most important point. Your exam is going to test you on the numbers, the meds, the procedures, but the real work, the real art of nursing happens outside of that. So I'm going to leave you with this to think about. Beyond all the clinical stuff we just reviewed, how are you going to be the one to truly empower a family that's just starting this long and often scary journey?